Welcome everyone. My name is Sergiusz Jóźwiak. I'm a pediatric neurologist from Warsaw. Thank you very much to organizers for inviting me to present the results of EPISTOP study during International Tuberous Sclerosis Research Conference in London. Epilepsy appears in up to 90% of patients with tuberous sclerosis, and in prospective studies, up to 70% of patients with tuberous sclerosis develop seizures till the end of the second year of life. Early seizures are very often associated with significant epileptic comorbidities as speech delay, intellectual disability, or autistic behavior. Recently, we learned how to very early diagnose tuberous sclerosis. Very often we diagnose tuberous sclerosis prenatally due to cardiac tumors on prenatal echocardiography or brain prenatal MRI. Our studies carried out in patients with tuberous sclerosis just from newbornhood. With EEG, we demonstrated that normal EEG is observed usually in the first several weeks after birth. And somewhere in the end of the second month, in some of them, up to 70% of patients, we may observe some spikes, later multifocal spike and wave complexes. And at this stage, sometimes we are able to observe subtle focal seizures. If they are overlooked, the epilepsy evolves into generalized activity, hypsarrhythmia on EEG, and infantile spasms. Here there is a short video demonstrating just a very short seizure in this infant. You can see the rotation of the eyes to the right, nystagmus, and extension of the right hand, abnormal breathing. Everything lasts 15-20 seconds and ends and child is again awake. The significance of and utility of electroencephalography for identification of infants with high risk of epilepsy development was confirmed by the group of Joyce Wu and Martina Bebin. These researchers found in the group of 28 patients with early diagnosis of tuberous sclerosis with EEG done at 1.5, 3, 4.5, 6, 9, 12, 18 and 24 months. They found in this EEG that in the group of 28 patients, 9 of them had normal video EEG and had no seizures. 5 of them had normal video EEG and no seizures, and 14 had abnormal video EEG, and subsequently this group of infants developed seizures. So all 14 patients with paroxysmal video EEG abnormalities developed epilepsy. In 2011, we also published our results, demonstrating the results of this preventive treatment with vigabatrin of patients with abnormal video EEG changes. In this study, we compared two groups of patients. Standard treatment group, 31 infants with very early diagnosis of tuberous sclerosis treated when they developed first seizures, and preventative group, 14 patients who just from very early infancy had multiple electroencephalographies. And in this group, when we carried out EEG every 4 to 6 weeks, when they had abnormal EEG, we started to treat with vigabatrin with the dose 100-150 milligrams per kilo. And the results of the study are presented in this table. You can see that the number of those with epilepsy was not statistically significant. This difference was not statistically significant, but it was a lower frequency of those with epilepsy in preventative group. But this group, preventative group, had also less infantile spasms, less patients requiring epilepsy polytherapy, drug-resistant epilepsy, and in this group there was a higher number of patients, seizure-free patients at 24 months of age. What was very important, the mean IQ score at the age of 24 months was much better in this preventative group. And we had no patients with severe form of intellectual disability. In 2019, we published the results of follow-up study of these patients. So these patients at that time had 7 to 9 years of age. And in this age, we also could observe that this preventative group had higher mean IQ score. These patients had less intellectual disability and also less epilepsy. When we look at this table and this graph demonstrating particular patients from preventative group, we may see that there, in the group of 14 patients, we had 3 patients with completely normal EEG during 24 months of age, and later on up to the age of 7, 9, they haven't had any treatment and they had no epilepsy. There was 4 patients who were on treatment, these red bars, due to abnormal electroencephalography. But after some period of time, this treatment was discontinued and these patients never developed epilepsy and they were without treatment. There was a group of 2 patients who had clinical seizures, were on treatment, but after some period of treatment, the treatment was discontinued and these 2 patients had no seizures, no treatment. So in total, in the group of 14 patients, 9 patients had no treatment and no epilepsy. And there was also a group of 5 patients who were on treatment and some of them had also epilepsy, active epilepsy. In 2013, we started EPISTOP trial, a long-term prospective study evaluating clinical and molecular biomarkers of epileptogenesis in a genetic model of epilepsy tuberous sclerosis complex. There was a group of 16 sites in Europe, United States, and Australia. We had 2 aims. The study had 2 aims: to prove that early treatment of subclinical seizures significantly reduces drug resistancy and neurodevelopmental delay in children, and that prospective analysis of clinical and molecular biomarkers, genes and proteins expression in the course of epileptogenesis. The primary endpoint of the study was time from birth to first clinical seizure, and there were several secondary endpoints at 24 months of age. There was proportion of patients with clinical seizures, drug-resistant epilepsy, history of infantile spasms or hypsarrhythmia on EEG, autistic features, and neurodevelopmental delay. There is a graph presenting a protocol of the study. You can see that we started with infants at the first 4 months of life with the diagnosis of tuberous sclerosis and without any EEG abnormalities. We carried out EEG every 4 to 8 weeks in this group of patients, and when they reached a certain point of a certain threshold on EEG, the patients were randomized into preventive and conservative treatment and observed until 24 months of age. During this evaluation, we also collected blood samples for molecular studies. There is a graph presenting the flow chart of EEG scoring. The EEG was assessed by local electroencephalographer according to established EEG threshold, and the information that the child reached the threshold was sent to central randomizer, who randomized these patients into standard and preventive treatment, and information was sent by the randomizer to the local treating neurologist, treat or not to treat. So they didn't know what was the exact reason of the treatment. There is a flowchart of the patients in the study. You can see that we enrolled 101 patients and 7 patients dropped out due to misdiagnosis. 94 were included. Again, after the inclusion, 7 never had epileptiform activity or seizures, and 4 dropped out before epileptiform activity was found. 7 patients had discordant EEG interpretation, and 22 had either clinical seizures or electroencephalographic seizures before randomization, so were not included into randomization. And 54 were eligible for preventive treatment. Again, at this point, the parents were allowed to choose whether they wanted to be in the randomized part or they wanted to be in the particular part of the study, I mean open label part. They wanted to be treated preventively or they wanted to be treated in the standard way. So in fact, we had 2 groups of patients, 27 patients in the randomized control trial and 27 patients included in open label trial. And in both of these groups, we had preventive treatment and conservative treatment groups. Primary endpoint. Preventive treatment delays onset and lowers the frequency of seizures. You can see that in the randomized and in observational groups, when we compare preventive and conservative treatment, always the preventively treated group had much delayed onset of seizures comparing to those who had who received conservative treatment. Secondary endpoints. When we analyzed the randomized control trial and open label trial, we could confirm only statistically significant difference in the randomized group in drug-resistant epilepsy evaluation. Those in the preventive group had less drug-resistant epilepsy, and in the open label trial we found the statistically significant difference in the appearance of infantile spasms. Again, in the standard treatment group, there was much higher incidence of those patients with infantile spasms. When we combined these 2 groups, randomized and open label, you can see that we obtained statistically significant differences. Again, in clinical seizures, much more seizures were clinical seizures were observed in standard treatment group. There was also higher proportion of patients with drug-resistant epilepsy and with infantile spasm. It is important to note that infantile spasm were observed exclusively in the standard treatment group. Also, patients without epileptiform activities and seizures had no autism or a neurodevelopmental delay. It is very important to mention that both preventive and conventional treatment groups in EPISTOP had very frequent visits with video EEG. As a result of such frequent visit, none of the patients in EPISTOP in any of the group had severe learning disability. Cognitive developmental quotient below 50 at age 2 years. It's a big difference between EPISTOP and previous our studies, where we had a really conservative treatment when the patients were sent home and asked to come with seizures. In EPISTOP, also in this conservative treatment group, those patients were seen very frequently, and many EEG studies were done, which allowed us to diagnose epilepsy much earlier. Also, all patients without epilepsy and epileptiform EEG had normal intellectual function, supporting the concept that epilepsy is the main contributor to intellectual disability in tuberous sclerosis. I would like to just to mention just a few additional studies and papers published by a group, EPISTOP group, the group of Lieven Lache, who was a leader of EEG team. He is on the left. He demonstrated in this paper that 95% of patients had at least one abnormal EEG, but it was also EEG with some focal spikes, which was not yet a threshold for randomization. And particularly this graph on the right is very important, because you can see that this graph demonstrates interval between first EEG with epileptiform discharges and first seizure. So again, we can see that the preventive treatment delayed the onset of seizures in this group on treatment, while those in the conservative group had a relatively short gap between first abnormal EEG and seizures. And also here you can see that this preventative treatment group had less epilepsy, say 60%, comparing to 80% of those on conservative treatment. The same group in the same paper also analyzed the in the Bailey infantile scale the development of these patients in different cognitive and language and motor development, and we see that the young age at first epileptiform discharges was significantly associated with lower cognitive, language and motor development at 24 months. Here you can see those on the left part of the slides. You can see on the graphs, you can see those with the early epileptiform abnormalities with much poorer development in all three scales. In the paper written by Paolo Coratolo and Romina Moavero, who were the leaders of the neurodevelopmental group, I would say, assessing autism and neurodevelopment in EPISTOP, they also found that some abnormalities in ADOS scale were also observed in patients with autistic spectrum disorders at 24 months. You can see that those who developed finally autistic spectrum disorders also had some abnormalities at 12 months and 18 months. So these changes were seen at this age. Even if they looked at with the Bailey scale, these changes were even earlier observed. You can see in these cognitive and motor scales on the left and on the right. The first lines starting at 6 months differ between those with autistic spectrum disorders and without autistic spectrum disorders. At 6 months, these groups didn't differ between them. They start at the same point, but lately they diverge into between these two lines, between these two cohorts. And in the end, just the one paper from the genetic group of David Kwiatkowski We've targeted massively parallel sequencing, genome sequencing, and MLPA pathogenic variants. There were identified mutations in 93 of 94 subjects, or so it is 99% of patients. And more severe phenotype was detected in TSC2 pathogenic variants than in mosaic TSC2 or pathogenic TSC1 variants. But detailed genotype-phenotype correlation is available in the paper. Unfortunately, I had no time for the presentation of the results in this very short presentation. In the end, we did also just recently published a paper, the responses from the survey from centers treating tuberous sclerosis in different countries. 60 respondents answered our survey from 23 countries, and 95% perform at least one EEG before epilepsy onset, and 70% conduct regular EEG monitoring, and 51% respondents introduce anti-epileptic drugs when EEG shows epileptiform discharges. So the last slide and take-home messages. Recent EEG studies prove that video EEG is a good biomarker of epilepsy development. Early appearance of slow background activity is predictive of epilepsy onset. EEG surveillance significantly reduces the risk of severe intellectual disability, and preventive treatment may decrease the risk of clinical seizures, drug-resistant epilepsy, and infantile spasms. And EPISTOP study demonstrated that preventive treatment decreased the risk of intellectual disability, but didn't influence the risk of autistic spectrum disorders. Here are just two pictures taken during our discussions during the EPISTOP project. I would like to thank our patients and all members of EPISTOP Consortium for their hard work during the 5 years of the study. Thank you very much.